So certainly this patient has borderline pulmonary function and wasn't a candidate for surgery, and so we treat him with some caution. Any radiation is going to decrease his pulmonary function tests. Generally, I get pulmonary function tests again after radiation's complete. That's certainly not compulsory. But this is a patient in whom we're starting a checkpoint inhibitor, and we would watch him carefully afterwards. So if patients have toxicity from chemotherapy and radiation, so if they're requiring steroids or requiring oxygen at the completion of chemotherapy and radiation, I would certainly hold back. But this gentleman had small volume disease and tolerated it quite well, so we were eager to start Durvalumab. And subset data appears to show that early initiation of Durvalumab is also important and may be correlated with a better survival outcome, may be correlated with a better progression-free survival outcome than later initiation. In the Pacific study, patients received Durvalumab for a year, for 12 months, every 2 weeks. And until I have more data, I think that's what I'll end up doing. Certainly, that's a lot of therapy for a patient. About 2 months of chemotherapy and radiation, followed by a year of every 2 weeks Durvalumab. At this juncture, we'll stop, but again, it'll be interesting to see what overall survival looks like and whether that is the appropriate thing to do. Like any patient who's undergone chemo radiotherapy, toxicities can emerge at any time, and although we see acute radiation pneumonitis, most of our patients who develop radiation pneumonitis do so down the road. And so we counsel patients, regardless of checkpoint inhibitors, to call us if they develop any shortness of breath, fevers, chest discomfort, and so we can evaluate them quickly. I think that message is fivefold intensified in patients with immune checkpoint inhibitors, that certainly any change in symptoms would necessitate timely evaluation. Patients, luckily, with this regimen are seen every 2 weeks as it's approved at this juncture, and we would imagine that any cough that's unexplained, any fever, any desaturation prompts evaluation. On top of the pneumonitis, there's all of the other autoimmunity that we see with checkpoint inhibition. So we would routinely check things like TSH. We would routinely do a thorough review of systems with our patients. Has there been any skin changes, any GI changes, any lightheadedness? Certainly, I think all of us who are giving these drugs have seen a multitude of symptoms that can happen at any point during therapy.